Welcome, everyone, to this evening's event, which is the third in a series of community forums focused on innovative solutions to complex social and public safety problems. I am Hill Kamen, Director of Public Health and Safety for the City of Everett, and I will be the moderator for this evening's forum, which will focus on partnerships between law enforcement and human services and social services and public health. And you will have an opportunity to learn how other communities have successfully implemented these partnerships and hear about some of the challenges facing Snohomish County around homelessness, mental health, and opioid and heroin addictions. Our guest panel tonight will include representatives from Snohomish County, Everett, City of Shoreline, King County LEAD program. Unfortunately, City of Bellingham could not make it this evening. I know they were on the flyer, but they were here for some meetings this afternoon, and we will include their information on our webpage if you are curious about their homeless outreach team. Before we introduce our guest panelists, you will also have an opportunity to hear about some of the work being done by the Health District and its assessment of heroin and opioids in our community. Snohomish County is a strong example of collaboration between law enforcement and social services, nonprofits, private enterprises, and between cities and the county. We are lucky to have leaders in this community who are so aware of the challenges that we face and who are not only looking for innovative solutions, but are already out there implementing successful ideas. Tonight's forum is hosted by 4 leaders in public safety innovation: Everett Mayor Ray Stephenson, County Executive Dave Summers, Sheriff Ty Trenary, and Everett Police Chief Dan Templeman. I would like to invite Mayor Stephenson forward to give a welcome message for tonight's forum.
Well, good evening. I'm very happy to see all of you. I hope I'm not in competition with Donald Trump. I think this is where all the smart people are. Anyway, it's wonderful to see all of you, and I want to thank our panelists before they get started for participating this evening. We had a very enlightened discussion this afternoon with elected officials, and we continue to learn. This is a new process for the City of Everett and Snohomish County, and I can tell you, I'm absolutely convinced we are on the right pace to make a difference in our community. As Hill mentioned, this is a continuation of our Safe Streets forums. As you know, we've talked about a number of issues, and we're working very hard to deal with supportive housing for the homeless. Tonight, we will talk about enforcement and outreach and how our law enforcement professionals are finding new ways to keep our community safe and support our most vulnerable citizens. And I think of all that we've accomplished as a community over this last year. I'm so grateful for the commitment of our first responders, social workers, nonprofit organizations, businesses, and neighbors who have a stake in making Everett a safe and inviting community to live and work. I want to take a minute to recognize our Streets Initiative Task Force. If there are members here, I'd ask you to stand, and if you would just thank them, even if they're not here, please thank them for all their great work over 6 months to develop the plan. I want to acknowledge our elected officials as well. I know Everett City Council member Scott Bader is here, Judge Joe Wilson. Are there others here? I know we had a number of elected officials this afternoon, Ty Trenary, who you'll hear from in a moment as well. But let's thank them for all their support as well. And so I mentioned this afternoon Executive Summers, who is unable to be with us here tonight, and Sheriff Trenary and Chief Templeman had a very productive afternoon talking about our criminal justice system and how we are adapting to a changing world and the challenges of homelessness, mental illness, and addiction. As you know, in Everett, we're taking a very comprehensive approach to solving these issues and focusing on housing, diversion, enforcement, and outreach. And tonight we will talk about the last leg of that stool, enforcement and outreach. I've always had a tremendous respect and gratitude for our police officers as well as our sheriff's deputies in the county and the way that they protect our community. But I can tell you over the last couple years, I've been more proud than ever at the innovation, compassion, and effective way our officers are interacting with those on the streets. And you're going to hear about that this evening. And our officers don't always have contact with all of you for you to see how they're interacting, but it is very difficult and challenging work. So I want to thank, again, the panel for being here. You're going to find that these professionals have been doing incredible work in their communities for a number of years, and we want to learn from everyone who's doing it right. And I want to thank all of you again for being here. And now I'd like to introduce Sheriff Trineri. Sheriff?
Good evening, everyone. I appreciate you being here. I want to echo a little bit of what the mayor said. It's nice to see support from the community. I know that if you've been watching this process, it probably feels like it's taken a little while. And I'll just be very candid with you and tell you that this is not a simple solution. If there had been a magic pill or some kind of magic formula, I assure you Chief Templeman and I would have enacted that quite some time ago. We've been really, really, really fortunate in our county to kind of have the sense of community that we do. So let me share what that means for just a second. So in many places, and certainly not to pick on King County because they're here tonight, but we find that law enforcement is kind of a territorial lot. We talk a lot about jurisdiction, and we wear different uniforms, and we drive different cars because we really kind of believe in our little personal place on the planet that we protect. But very candidly in Snohomish County, for many years, our law enforcement agencies have worked very, very well together. We don't really worry about borders or jurisdictions as much as we worry about the problem. So this has been it's kind of been a rocky road for us in understanding how bad the heroin epidemic is, understanding its impacts to homelessness and specifically mental illness, and then trying to figure out a way to fix it. I can't quote him exactly because I didn't print it off, but I found the comments by the Dallas police chief last week very, very interesting in that he talked about how we use law enforcement for everything. And sadly, it's really the only tool in our toolbox is for society. And I think one of the things we've learned, certainly I've learned since I became sheriff, is we've got to kind of retool the way we do business. So for example, using our jail as the de facto mental health hospital is not an appropriate way to treat people, and it's certainly not an appropriate use of that facility. Taking low-level offenders who have an addiction and trying to treat them through the criminal justice system through arrest and incarceration not only doesn't treat the problem, but quite frankly, it's the most expensive process to us as taxpayers, with almost no results. And so I've had an opportunity to hear about some of the programs you're going to hear about tonight. I got to listen to this presentation earlier. What I found was there's hope. There's hope in the notion that the kinds of things that we're doing in partnership with the Everett Police Department by embedding social workers, you're going to get to hear from them, and they can talk much better than I can, about the idea that a police officer and a social worker ride in the same car together, and they go out and deal with our critically dependent population. I make this joke all the time, and it's gotten old, but if you told me 20 years ago my partner in a patrol car was going to be a social worker, I would have laughed at you, quite frankly. But the idea is now we go out into a homeless camp, or we go out to problem locations, and we spend the time to figure out what's really going on. So if someone has an addiction issue or a mental health issue, instead of writing a report or using a pair of handcuffs, the social worker and the police officer, deputy sheriff, spend time trying to find, okay, what kind of program can we get them into? And then, and the idea isn't, hey, we'll give you a date and we'll see you in 3 months, because that doesn't work. The idea is, what do you need to take with you? Let's pack it up, let's take you and get you to a program. And quite frankly, and I know Chief Templeman and I talked, we've had to put good to go passes in the patrol cars that my folks use, because very often we're taking a ferry across to Kitsap County, or we're down in Thurston County, because that's where our treatment options are. And we've learned the hard way that if somebody raises their hand and said, I keep seeing you guys show up and good things seem to be happening and I've hit rock bottom and I want help, that we need to take them right then. A referral and a waiting list doesn't work. And there's lots of anecdotal evidence to show why we're in the shape that we're in. Like any good politician, I love to talk, but I think there's some really good information. What I will share with you is I will echo what the mayor said. We think we've found the way to get us to back to a place where we feel safe. It's a long road. And unfortunately, it's not just an Everett City problem. It's a problem all over the county. I live out near the Lake Goodwin area. If any of you know where that is, it's a fairly rural area. And we have problems there just like we do in the city of Everett. And so as we've learned from what Everett's done, we are trying to expand that stuff into the county. All I would ask for is your patience. Because as I mentioned to begin with, and I think Lauren will talk a little bit about, when a deputy and an embedded social worker go out, they may only make 1 or 2 contacts in an entire shift. Because if somebody says, you know what, I'm ready, I'm a heroin addict, and I want help, and they can get them a bed, they may spend the entire day working that process. There's a whole process to that, but the idea is we get them help and then we're waiting for them when they graduate, hopefully with job training and some kind of housing, and you're gonna hear a lot more about that. But the idea is, let's fix them, let's get them back into society and keep them out of our jail, knowing that that's the right way to go. So my message to you is, I think we're on the right path. Just ask for your patience. Thank you very much.
Thank you, Sheriff. All of these innovations are occurring in a backdrop of a regional and national opioid epidemic. So now we're going to hear from Heather Thomas at the Health District to talk about that epidemic as it is playing out in our local community, and to share some information about the extent of that reaching into the lives of the people who live here.
As Hill said, my name is Heather Thomas. I'm with the Health District, and we thought before we look at some of the law enforcement solutions to this problem, we might look at where we're at today and how we got here. So a few stats from the national level. We'll start at the national level and work our way down. From 2012 to 2013, the rate of heroin-related overdose deaths quadrupled. The heroin use in 18 to 25-year-olds and females of all ages doubled. And the heroin use in non-Hispanic white men more than doubled. And that's over just an 11-year period. When you step down a little bit lower to the state level, this is a graph of opioid deaths here in Washington from 2000 to 2014. So the blue bars are prescription opioids, and the red bars are heroin. You'll see around 2008, 2009, that's where we peak on prescription opioids. And the reason for that is the manufacturers actually changed the formulation of oxycodone so that it was an extended release tablet. So you no longer could take multiple tablets to get high quicker. As that started to change, heroin was ready and available in the wings, and you start to see the heroin deaths come up behind it. Next. Here in Snohomish County, we represent about 1/10 of the population for the state of Washington, but in 2013, we had 1 out of every 5 heroin deaths here in Snohomish County. Of those, 2 out of 3 were males, and most of them were 18 to 29-year-olds. One more time. Even more frightening, as a mom to 3 young children, when we look at our Healthy Youth Survey, this is done every 2 years of 6th, 8th, 10th, and 12th graders. Our 2014 survey found that 1 in 4 sophomores do not think it's a big problem to be using illegal drugs. That's 1 in 4. Next, we have 1 in 17 seniors have admitted to using heroin. And even more distressing for me is 1 in 20 8th graders admitted to already misusing prescription drugs that were not prescribed to them. That's 1 in 20 13 or 14-year-olds. So how did we get here? Well, it's a very interesting story about a molecule. I figured rather than explaining it myself, there's a book. Has anybody heard this? It's called Dreamland. It's by Sam Quinones. If you haven't, I'd recommend reading it. It's a fascinating read. And he did a research about the opioid addiction here in America, and he interviewed Andy Coop, who worked for Bristol Pharmacies and the University of Maryland. And he wrote, "What gave the morphine molecule its immense power," he said, "was that it evolved somehow to fit, key and lock, into the receptors that all mammals, especially humans, have in their brains and spines. The so-called mu-opioid receptors, designed to create pleasure sensations when they receive endorphins that the body naturally produces. They were especially welcoming to the morphine molecule. The receptor combines with endorphins to give us those glowing feelings like when we see an infant or the feel of a furry puppy. But the morphine molecule overwhelms the receptor, creating a far more intense euphoria than anything we could ever come by internally. It also produces drowsiness, constipation, and an end to all physical pain. Aspirin had a limit to the amount of pain it could calm, but for the more morphine you took, the more pain was dulled. The morphine molecule exerts a brainwashing on humans, pushing them to act contrary to their self-interest in pursuit of that molecule. Addicts betray loved ones, steal, live under freeways in harsh weather, and run similarly horrific risks in pursuit of the molecule. It became the poster molecule for an age of excess. No amount of it was ever enough. The molecule created ever higher tolerance. Plus, it had a way of railing on when the body gathered enough courage to throw it out. And this wasn't only during withdrawals. Most drugs are easily reduced to water-soluble glucose in the human body, which then expels them. Alone in nature, the morphine molecule rebelled. It resisted being turned into glucose and stayed in the body. Quote, "We still can't explain why this happens. It just doesn't follow the rules. Every other drug in the world, thousands of them, follow the rule, but morphine doesn't. It's really as if someone designed it that way, diabolically so." So here we have a very unique drug that our bodies are hardwired to respond to. Go to the next slide. It's also your body responds to it the same way oxycodone. I won't go into the chemistry piece, but they're almost identical. But what's not identical is how it affects your pocketbook. Oxycodone is about $80, whereas heroin's $10 and much easier to get. The University of Washington Alcohol and Drug Abuse Institute recently published a report on drug injectors from around the state. They surveyed just over 1,000 drug users from around the state, and 57% of those said that they were hooked on prescription opioids before they started heroin. The average age at the first time of injection was 24, but this is the average age. If they looked at all the responses, the youngest was 8, the oldest was 59, and the most common age was 17. But how do you go from abusing pills to heroin? The first piece is access. There was another study done in 2014, and they found that at a rate of 100 people, so just a little bit less than this, 85 of them had prescription opioids. That's all people, including children. So if you think about how many people are in this room, many people had multiple prescriptions. So our teens and other people have ready access to prescription opioids in their home. Most teens get them from their own prescription, about 33%, a friend, 28%, a family member, 10%, or they took it from another home for 9%. Once they have access to that, they try it and they either hate it or they like it. And this is usually a physiological response. You physically feel ill and you don't like it and never want to take the pill again, or you respond well to it, you love the way it fills a hole of some kind, physical, internal, and you want more of it. It also has to do with set and setting. Obviously, it's cooler to use prescription opioids if you're around a bunch of friends than it is by yourself. If you have others trying it, you might have peer pressure. And then you start to use more of it. Your body wants more of it. You start taking more often, or you might run out of your prescription, and so then you start looking at other options. And you start to create a physical dependence. Morphine changes your brain structure. It makes you want it more. You can make choices to stop, but usually you can't. Because of this physical dependence, you start a cycle of withdrawal and hating the feeling, and so you try to get more. And that's usually where you move, again, onto snorting or to injecting heroin. Go ahead, press. And that's the addiction. This is where heroin or prescription opioids become more important than anything else in your life, and you'll do whatever you can to get it. So once you become addicted, what's the next thing? Well, the most important thing for addicts is to make sure they have access to naloxone or Narcan. For those that aren't familiar, it's a life-saving drug. It can be injected or used intranasally, and it will reverse the effects of an overdose. I've seen it happen firsthand. In a matter of 2 or 3 minutes, the person is breathing again. There is the notion that naloxone or Narcan is a safety net, that it just allows people to continue overdosing or to continue using the prescription drugs or heroin. An addict is going to continue using. You can't help an addict who's dead. The other thing is, because it feels so horrible to come out of withdrawal, they continue using. Naloxone pulls you out of withdrawal in 2 to 3 minutes. So it's far more severe withdrawal symptoms than just normal. Go to the next one. So looking at addiction, you have to solve 2 things. The first is the brain changes and your dependence on the drug. And then the second is the psychological and social problems. You have to have 2 different solutions to have the best outcome. So the first is usually looking at opioid addiction treatment medications. And this helps your body stop the physical dependence so that you're no longer craving that, so that you can address the other problems, which is typically counseling and social supports. So a little bit more about medication-assisted treatment. There are several different kinds. Just like any type of illness or any type of prescription, some work better for others than a different kind. One is methadone. This is typically done in a clinic. You go every day at the same amount of time. You get a little vial. They're highly regulated. You have a waiting period here in Snohomish County. There's about 150 on the wait list at any given time. And it's also a full opium product. So you have to make sure that you're watching it and that you're not overdosing or allowing people to abuse it. The next is buprenorphine, also known as Suboxone. This is a product that under Suboxone is mixed with naloxone. So you have an opioid product and naloxone to help prevent the overdose. This can be prescribed by a physician in the clinic. There's a little less restrictions. However, there's certain complications in that physicians don't necessarily want to prescribe Suboxone. There was a federal law that goes into effect August 5th. Up until then, you could only have 100 patients prescribing Suboxone. As of August 5th, you can have 275. But we have a number of physicians that don't want to be known as the Suboxone doctor. So that's something that Dr. Goldbaum with the health district is working with the medical community to try to solve. And the other option is Vivitrol. This is a relatively newer treatment. It's an opioid blocker, so it blocks the effects of opioids. It's an injection, and it can be done in a doctor's office. Results are still preliminary on whether this is effective or not in the long run, but early indications are it's a good option to consider. So that's a little bit about opium, or opioids and heroin. You'll hear a lot about the great work that law enforcement's doing, but you'll find they're also very popular. So our job in public health is to stop the lines at their door so that we can help work or curb the problem together. A recent study from the National Safety Council found that 3,600 people started misusing opioid painkillers today. That's 3,600 people nationally every day. It's also been found that $1 spent on prevention programs and early treatment for addiction saves $2 to $10 in health, criminal justice, education costs, and lost productivity. So what is the health district doing? Well, we've been working with the syringe exchange in Everett, giving them supplies and Narcan kits. We also have staff that go out and do jail outreach and working with drug injectors to test for hepatitis, HIV, and other health conditions. There tend to be abscesses or other infections with drug use. We've also been working, thanks to, we have a Board of Health member here in the audience, and the Sheriff's Department adopted a new secure medicine policy. Right now, there's 25 law enforcement stations around the county that you can drop off your unused medication. In 2017, that will be increased and paid for by the pharmaceutical industry. We're the 8th in the nation to pass such a law. And Dr. Goldbaum is also working with the medical community to minimize the amount of prescriptions that are out there for unnecessary reasons. If you go for oral surgery, do you really need a 60-day supply of oxycodone when you might only need 4 or 5? And finally, we're working to help build healthy and resilient families. Those that have had trauma or mental illness are at a higher risk of addiction, and the families that have had children, the parents that are addicted that have children, tend to perpetuate the cycle. So we do a lot of work out in the community to help stop that. Moving forward, we'll be focusing on a few key areas. Prevention, we want to expand the work that we're doing with the early childhood, mostly 0 to 5. Working with human services in the school districts to have more trauma-informed care and trainings available in our schools. And social marketing or behavior change programs. Looking at response, Dr. Goldbaum is about a month away from making opioid overdoses a notifiable condition. This is similar to measles or pertussis, where the health district is notified. It gives us better access to data to know how many people are either dying or overdosing, and it also gives us a critical link to go back to doctors to let them know that their prescription was used in an opioid overdose. There's not usually a closed loop on that. Continuing to bolster our support with the syringe exchange, and also working with the county and cities to look at a needle cleanup countywide. We hear reports of needles in parks and in homes, and so we're looking at ways that we can help work together to clean that up. And data evaluation to make sure that the programs that are in place are effective. And then looking at treatment or recovery, increased access to naloxone kits in partnership with human services, increased access to treatment, that's again working with Dr. Goldbaum and the medical community, and more group and support education. We go out to Therapeutic Health Services, to Cocoon House, and to Everett Gospel Mission to work with vulnerable populations so that the children that they are keeping have a better chance at resiliency and a better chance at life. In closing, a couple of points. We'll be hosting, in partnership with Human Services, a couple of regional heroin forums. Those will be announced in the coming weeks. There'll be 3 to 4 around the county. It will include panel members and a Q&A session, as well as free naloxone trainings afterwards for those interested, and resource tables to get more information. And then for a couple more resources, stopoverdose.org is a website housed by the University of Washington, has some great information. Drugabuse.gov, or you can visit the Snohomish Health District website. Thank you.
Thank you, Heather. Paints a very daunting picture of the challenge in the community. And so now we're going to hear about some of the innovations and the collaboration that is underway to address that. And only through these partnerships between law enforcement and public safety and health will we make any headway on this effort. So I will introduce the panel now, and then they will have some time to talk about the variety of programs, and we'll have an opportunity for you to ask questions at the end of that presentation. From Sheriff Ty Trineri's Sheriff's Department, Lauren Rainbow is an embedded social worker who is embedded with the Office of Neighborhoods. Next to her is Caitlin Dowd, the embedded social worker for the Everett Police Department. Chief Dan Templeman, who has led the way in innovations in Everett with the Community Outreach and Enforcement Team and a partnership with the National PARI program. Moving down, retired Captain Scott Strathy, formerly of the King County Sheriff's Office, and now with the City of Shoreline and the Radar program. And I will let them explain what Radar stands for and how the program works. Next to him is Deputy Tim Meyer with the King County Sheriff's Office, City of Shoreline. And the remaining panelists are all here from a large team that works really well together and presents really well together. They're all from the King County LEAD program, Law Enforcement Assisted Diversion. We have Chief Deputy Jim Pugel from the King County Sheriff's Office, Sokha Don from the Neighborhood Safety Advocate from the Public Defender Association, Cathy Speelmon, the Law Enforcement Assisted Diversion Program Manager at REACH Evergreen Treatment Services. Then Chad Winfrey, Officer Specialist at Department of Corrections Neighborhood Corrections Initiative. And Natalie Walton Anderson, the Criminal Prosecutor from the King County Prosecutor's Office. So, Chief, do you want to get started? Sure. Okay, thanks.
All right, thanks, Hill. I appreciate it. I guess first and foremost, I want to start by saying that what you're going to hear tonight when you hear from all the different panelists is you're going to hear about partnerships. And I think it's already been talked about a couple different times that what we're doing in Snohomish County and what's going on in King County and in other jurisdictions around the country could not be accomplished without partnerships. No single entity has the resources, the staffing, the expertise to be able to deal with the complex issue that we're facing as a community. And I want to talk momentarily about that. I've been doing this job for 24 years now, and I can say that what I'm seeing on the street and what our officers are experiencing on the street, what our social workers are seeing, is something that I've not seen in my career. And it's not just a single issue. It's issues that are associated with what the health district just presented, the heroin and opioid epidemic, and I would call it an epidemic in terms of what we're seeing. Untreated mental illness and issues surrounding that, and homelessness. And in a lot of cases, they're co-occurring. You know, it's not just one issue, it's more than one issue, and sometimes all three of those. And so those present very, very complex issues for those of us in law enforcement to address. And the sheriff spoke about it earlier. It's been spoken about by the Dallas chief about everything, all the different issues and responsibilities that have fallen at law enforcement or first responders' feet. And it's not just law enforcement, it's the fire personnel that are out there as well dealing with a lot of these issues. And that's why we've had to rely upon these partnerships in order to accomplish what we've accomplished. I think that we still have a long way to go, but I think we're on the right track. And so what I want to do right now is take about 5 to 10 minutes to talk a little bit about what the Everett Police Department is doing and some of the innovative programs that we've been involved in. And I want to start by talking about probably, in my opinion, one of the central pieces of our program up here with the Everett Police Department and the Snohomish County Sheriff's Office, and that is our law enforcement embedded social worker program. And I'll let both of Caitlin and Lauren talk more about what they do specifically, but I just want to talk about why we brought it up here to Snohomish County and why I think that we're leaders in law enforcement with this program. Back in 2013, we sent a couple of our officers that worked our downtown patrols, bicycle patrol, down to Santa Monica PD. We had heard that they had a pretty effective program down there dealing with issues surrounding homelessness, mental illness, and drug addiction. And so they went down and spent a week down there observing this unit operate. Different environment, different revenue streams that we don't necessarily have available to us up here in Snohomish County, but a very robust program down there in Santa Monica. And when these officers came back, the whole goal of sending them down there was to come back with ideas and proposals. And what can we do? What can we learn from what's going on down in Santa Monica that we can implement up here in Snohomish County and in Everett? And there were a lot of different ideas. There's a lot of different programs out there. A lot of them have pretty significant price tags attached to them. But the one program that both of the officers were adamant that we needed to really look at was this law enforcement embedded social worker program. And the purpose behind this is our officers were encountering the same individuals on the street over and over and over again. And the officers were getting frustrated because they'd get 911 calls. Sometimes these individuals weren't even committing crimes, but people would call 911 because they were concerned, they were acting strange. The officers would show up, and in the cases where they weren't committing crimes, or even if they were usually minor crimes, and quite often, if we were able to arrest them, they wouldn't meet the jail booking criteria, so we'd have to release them anyway. And so this was a frustration for our officers. It was a frustration, I think, for our citizens and business community to see us come out and respond to some of these calls. And, you know, the citizens watching from afar, they don't understand the conversation that's occurring. They don't know some of the restrictions that we have. And then they see us get back in our police car and drive away. And it's like, how did you just solve this issue? And really we didn't. And again, it was a frustration for our officers. Our officers on the street today, are responding to calls pretty much all their entire shift. They respond, they take a report if that's appropriate, or they handle whatever the issue is, and they move on to the next call that's waiting. And this is what they do their entire shift. They did not have the expertise, they did not have the time to dedicate to dealing with some of these complex issues that I've spoken about. And so what the social worker allows us to do is we team up with the social workers, and we can, right there at the street level, divert some of these individuals and get them the help. The sheriff spoke about, when that individual says, okay, I'm ready to go get help, and sometimes it takes months and years, and sometimes it never happens. But when they do tell us that, we need to act right then. And that's what this resource with the social workers allows us to do, is introduce the social worker. And quite often, there is a lack of trust between some of these individuals and the officers. And so introducing a social worker really kind of lessens the stress, I think, with some of these individuals. And they're able to make connections. The social workers, again, and I'm going to let them talk more about it, but they have that knowledge and expertise that we don't necessarily have, that they can utilize in order to divert these individuals and get them into services. It didn't make sense, and it still doesn't make sense, to arrest some of these individuals for low-level offenses, put them in jail, if we can get them into jail. They spend an average of 12 days in jail, and during that 12 days, you as the taxpayer are paying for their stay in jail. It sometimes can be up to $200 to $250 a night in jail. You're paying for all of their prescriptions. You're paying for any medical care that they need. And then they're released 12 days later on average. And what do? They go right back to where we arrested them the first time, and they engage in the same behavior again, and it's this cycle. And so even our officers realized that was not effective. And so I think that we've seen a culture change with our police officers. The sheriff mentioned, and I would echo, that 24 years ago when I started, never would have thought about having a social worker in a police car next to me. Today, I really believe, and I've heard this from one of our officers that had moved on in an exit interview, I wish there were more social workers because we don't have access to the social workers at night. It kind of surprised me, but that's the culture shift that is occurring in law enforcement. We're realizing that we will not be able to arrest our way out of this problem. We've got to look at alternate solutions and innovative policing. So I'll let them talk a little bit more about their experiences in a moment, but I do want to touch on a few other programs that the Everett Police Department is engaged in. And I'll tell you, it's really important, I think, from all of these jurisdictions that we look at a balanced approach. So it's not just, and it used to be enforcement. I mean, that is what police officers did. We went out and we, whatever the issue was, we tried to resolve it. If we could resolve it peacefully, great. If not, and we had to make an arrest, we make an arrest, we put people in jail. And that was really our only tool that we had. And we realized that we had to look at some of these other tools. So we've tried to create a balanced approach with our agency. So it's not just social workers, it's not just outreach, it's not just touchy-feely, feel-good programs. There's enforcement that goes along with it, and I think there has to be an enforcement component in order to sometimes leverage that to help convince individuals that maybe the better route to go is not to be in jail, but to be in a treatment program. And if those resources exist, and that's a whole nother challenge that we're facing. But our officers last year, as part of this whole issue that we were seeing, this heroin and opioid epidemic, all started carrying naloxone, or the Narcan, which you heard the health district talk about. So pretty much every law enforcement agency now in Snohomish County, through a partnership with the health district in Northwest Haida, carry this antidote, if you will, in their cars. And again, when we talk about things I never thought I'd see, this is another one of those. I never thought I'd see our police officers carrying this and using it, and they've used it many, many times. I believe the latest numbers from Snohomish County are about 50 reversals that have occurred in Snohomish County, and I think in Everett we've had about 25 or 26 of those already that our officers have been involved in, our first responders. So that was, again, another approach. Our community outreach and enforcement team, which our law enforcement embedded social workers are part of, again, is that balanced approach. It is a new unit that consists of 4 police officers, a sergeant, and 2 law enforcement embedded social workers. We're in the process now. Our second social worker will be starting on August 8th, and we're in the process of identifying these new officers for this unit. And these officers are going to have special training that will help them address some of the issues that we're facing. They're not going to be 911 driven, so they're going to have a little bit more time to be able to dedicate to dealing with some of these issues and working with the social workers, working with the prosecutor's office on diversion and alternatives to jail and incarceration. So we're really excited to get that unit fully up and running. We've had temporary officers in that unit for the last several months, and again, we're excited to get the full-time officers in there and get that program fully off the ground and running. Hill earlier mentioned this national program of PARI, and I don't know how many of you have heard of PARI. It stands for Police Assisted Addiction Recovery Initiative. It was started on the East Coast by a police agency, and the agency that started it, in Gloucester, Massachusetts, again, and I'm going to touch on this, that I never thought we would see this type of program either in law enforcement. And when I first heard about it, I thought, no way, this is not something that I'm interested in doing and that we would be doing here at the Everett Police Department. But what I found is that even these ideas that may initially sound crazy are exactly those ideas that we need to be looking at in law enforcement and government to deal with this program. But what this program allows individuals to do that are suffering from addiction is to come into a police department, and if they have drugs, if they have paraphernalia, they can turn it in at the police department. They will not be charged, and we will vet them. There's a process that we will screen them. But we will, if they're ready to go get help and go into treatment, we will work with that individual and a group of several providers around the country. None of them are really located here in Washington, because that is another gap that we have in the state of Washington, is lack of treatment centers, lack of detox centers. We have to send these individuals out of state. Mostly the ones that we've used so far are in Florida, Hawaii, and California. And so we're able, through this partnership, to work with these treatment centers and get these individuals into long-term treatment. And we kind of did a soft launch, and Lauren was part of that when she was working with us on this program, and Caitlin now is taking it over for the Everett Police Department. But we've been able to successfully place, now I believe, 6 individuals in long-term treatment. And these are individuals that, the stories are amazing to hear. Homeless for multiple years, addicted to drugs for multiple years, and now are in a long-term treatment program. And to this date, while it's sometimes difficult to track them because of HIPAA and other issues, I'm not aware of any one of these individuals that we've run into again on the streets of Everett. So again, it's a program that I think has a lot of potential. The real interesting part about it, and where the partnerships come into play, is that these treatment centers, many of them, cost on average about $25,000 to $30,000 a month for the treatment that they're being provided. And these treatment providers that have signed up to be part of PARI offer scholarships. And so as an agency, we're one of 3 agencies in the state of Washington that are signed up with PARI. We can get access to these scholarships, and so we are able to send these individuals out of state to long-term treatment at no cost to the taxpayers and no cost to the city, which is pretty amazing, this program. Problem that we're having right now is that as more and more law enforcement agencies learn of it, there are fewer and fewer scholarships available to get these individuals in, but we've developed some really strong relationships with some of these treatment providers. And I just want to mention briefly the last few items. The Chronic Utilizer Alternative Response Team, or CHART. We've talked a lot about this publicly. This is a group of individuals that represent a lot of different disciplines that all come into contact with some of our most chronic utilizers of police, fire, EMS, jail, hospital services. These are all members of this team, and they meet every week and identify individuals that are chronic utilizers or super utilizers of the system, and come up with specific tailored plans to help get these people out of the criminal justice system, help get them into treatment, help get them the services that they need. And we're seeing some very significant, at least preliminary, positive results from that, thanks to Dr. Fenn with Snohomish County Human Services that did some analysis of that, and we may talk about that a little bit later. The other item I wanted to just touch on, which is again a little bit different, and you'll hear about LEAD, which is I think it's a little bit different than what we're doing here, but we have also started a work crew program which allows our officers, right now it's our community outreach and enforcement officers, when they come into contact with individuals on the street and they may have committed a minor offense, so a trespass, maybe a possession of drug paraphernalia, the officer has the discretion to divert them to work crew instead of arresting them and booking them into jail, creating a situation where they may have fines that they're unable to pay for anyway, that eventually then goes to warrant and they end up back in the jail again. And we've seen some pretty positive results so far with this program as well. And we've had a lot of individuals into the program that, and I've seen some stories come out from the supervisor of that unit that are pretty touching in terms of the value that these individuals who, the value that they're getting out of it by going out and cleaning garbage along the streets, cleaning up some of those areas where they may have frequented and caused an impact on the businesses and citizens. And it's a program, again, that I'm very proud of, and thanks to Hill and others that have helped get that off the ground. And it's still in its very early stages, and hopefully we'll have more to report on that down the road. The last item I just wanted to touch on has to do a little bit with what you'll hear with the radar program out of Shoreline. When I first started, one of the first things I mentioned to you is that this is not just a single issue. It's addiction, it's homelessness, it's mental illness. One of the new initiatives that we've just started on this last year is crisis intervention training for all of our police officers in the Everett Police Department. And so there will be a state mandate next year that requires every police officer in the state to go through 8 hours of crisis intervention training, which really addresses, how do police officers and first responders deal with those in mental crisis? How do we de-escalate those situations and try to resolve them without using force, if at all possible? And so our program that we've put together is our training unit has worked with the Criminal Justice Training Commission to create a specific 40-hour curriculum for Snohomish County. So it's unique to Snohomish County. It talks about resources that are available here in Snohomish County for our first responders. And so instead of just 8 hours, we are requiring all of our police officers to receive 40 hours of this training. And we offer it once a month, and we've already gotten probably over 40 of our officers through this training, and it'll continue on. So in closing, for me, I just want to reiterate, this is a community issue. This is not just a police issue. This is not just a social services issue. It is a community issue, and one that's going to take all of our resources and all of our collective will in order to really turn this around and make a difference in our community. So thank you. Okay, we'll continue on down. Oh,
Thank you, Chief. My name is Scott Strathy. I proudly served with the King County Sheriff's Office for 30 years and retired last July. I had the opportunity to come back and serve my community in Shoreline because we received a federal grant to launch a pilot program in the city of Shoreline, a 3-year pilot. It's called Radar, Response Awareness, De-escalation, and Referral. And I just want to thank the mayor and Hill and the chief for inviting us up here to address you and kind of share what we're doing. I noticed some of you are taking notes, and if you would indulge me, if you could jot down smartpolicinginitiative.com. It's all one word, smartpolicinginitiative.com. That's the federal site that is set up to kind of monitor and expose the program that we're working on in the city of Shoreline. Clearly, we're not going to be able to discuss all the ins and outs of the program tonight, but there's a video there kind of explaining the process and just gives you a little more insight as to what we're doing down in the city of Shoreline. I'd like to start with a story, and it's a story that involves me. And 25 years ago, I was a patrol deputy for unincorporated King County. I was just finishing up my swing shift obligation. It was a rainy and dark late evening. There was still heavy traffic. And I got a call to a suspicious man wandering around the gas pumps at a local convenience store. So it was my district, and I rolled down there in my patrol car and got out of my car and went to confront, this individual, find out what was going on. And he clearly responded to me in a very fearful manner. I was doing everything I could to de-escalate the situation. He ran from me, ran out into heavy traffic. Again, it was dark, it was raining. Clearly, he was putting his life in danger. I followed him out there. I called for backup. We eventually were able to get the man down on the ground after about what seemed, like 2 minutes of fierce battle where he's grabbing on at my gun belt, and we're doing everything we can to take him into control. We finally get him under control. We handcuff him and we get him off to the side of the road. We called for aid. Aid responded very quickly, and we were informed that he had passed away during the struggle. It was a case of excited delirium. It turned my world upside down, shook my confidence in my abilities to perform properly as a police officer. We did some investigation, and we found out that this man had been decompensating at home for several weeks prior to this incident, and he had a co-occurring issue of a drug dependency. Of course, I'm thinking to myself, why didn't we know this before we, as first responders, were put in this situation? How helpful would it have been for us to be aware of this individual's challenge? 25 years later, I'm a captain at the Shoreline precinct, and our deputies respond to a crisis situation involving an individual with a mental health challenge. He's taken his family hostage with a rifle in the house. There's been some cutting with a knife. Eventually, the family is able to get out of the house, but our deputies are on scene. The individual exits the house, sees our deputies, and levels his rifle. We're put in a position where the only thing we can do is take his life, and that's what happened. Same scenario. The family knew this person was decompensating. He was sliding into a state of mind where he was fearful of everything, including police, probably at the top of the list. And he also had a co-occurring drug disorder. So you've got these two situations that me, as a captain with the sheriff's office, I'm thinking to myself, what do we do here? We need more information. When I go to the inquest for the shooting, that was exactly what I heard from our deputies on the stand. We need more information while we are responding to these crisis calls. We are just winging it. We're putting together a plan while we drive. It's not an effective or a safe way to do business. So, this brings us to Radar, which essentially it's an outreach, I don't know where we are on the slides here. It's an outreach effort by law enforcement, by King County, by the Shoreline Police Department, to identify who are those individuals that we know, not through some super secret back channel, but just through the fact that we have addressed these individuals numerous times in our community, and we know there's a high likelihood that we're going to return to that individual in a crisis event. So make our deputies aware of these individuals. Also, find out what are the behavior triggers or inhibitors for these particular individuals. The thing about, the chief mentioned CIT training, which is a crisis intervention team. That's kind of a general training about how to deal with people with mental illness. Radar takes that training one step further. If my friend the chief lives in my community and he has a particular issue, maybe a fear of first responders, it's to our advantage to know what his particular response to first responders is, as opposed to a general understanding of what a behavioral health issue is. So, response awareness, who are these people? De-escalation, which is subject specific. What is it we can do to make sure that, to lessen the likelihood of a use of force event when we're addressing that individual? And then the referral piece, which is sharing this information so all of the Shoreline deputies, no matter if you're working first shift, second shift, third shift, we all are operating from the same sheet of suggestive music in terms of how do we best address this individual with the behavioral health issue. That's Radar in a nutshell. We applied for and received a Department of Justice grant in January for a 3-year pilot. I can tell you it is really good news to be on the right side of the Department of Justice. They are supporting what we're doing. They're very interested in how we're going to cobble together this program. We have research partners that are assigned to us from George Mason University, the Police Foundation, and NYU Medical School. They are helping us to develop a training program where we can address these individuals in crisis and reduce the fear of the contact and heighten the trust that these individuals have with responding deputies. One of the things that the Department of Justice is looking for from us is the ability to replicate the program and do it at a low or no cost. We can all come up with great ideas that have a $500,000 price tag, okay? That's not reality. You know, sometimes I describe myself as the most dangerous man in the room because I'm a retired cop and I know where the skeletons are. But my point is going to be, you know, the city of Seattle has a lot of political juice, and if they need money for something, they got a pretty good shot at getting it. Everett, I imagine, probably a lot like the sheriff's office. I mean, you got to be very careful with, you know, the money you get and how you get it. Radar really is more designed for kind of that urban, or excuse me, that rural deputy that doesn't have access to the embedded social worker, that is responding to that porch, that front porch in times of crisis with very little information. If we can provide de-escalation and proper handling of individual information to those deputies responding in those rural environments, we're achieving pretty much the same thing as having that social worker there. I mean, it's not the same. I mean, you wouldn't be bringing that level of expertise to the door, but it's the next best thing. One of the things that we have is in our planning team is a mental health professional that the county has graciously given to us for planning purposes. We call this person a navigator, and the navigator's sole role is to work in a capacity of planned obsolescence, to help us as police first responders figure out what is this patchwork of supporting agencies that are on the horizon. How do we get individuals in need to the right people and make sure that there's ownership of that challenge? So that is, in a nutshell, what we're looking at in Radar. And I'll pass it on to my partner, Tim Meyer.
So I'm fortunate to be able to kind of bridge it from taking it from initiatives and slides and how do we actually apply it on the streets. One of the things that comes up, you can see the slide behind me here, is why now? In the King County Sheriff's Office, we provide contracting police services to about 16 different... I sure can. Thank you. So the question is, why now? And a lot of this is driven by the King County Sheriff's Office. We're fortunate to provide policing services to about 16 different contract cities. That's going to be Shoreline, where I'm assigned, Snohomish, Burien, a number of police partners out there, and they are demanding a more progressive product. That arrest, release, arrest cycle no longer works. Head to the next slide there. So the radar from a patrol perspective is that our riskiest and most chronic clients are motivated by chronic unmet mental health needs. That's what's driving a lot of these. It's going to be drug and alcohol abuse or acute crisis, and that ties in to the scenarios that the captain spoke of here. It's that random contact. We get dispatched to a suspicious person at the convenience store, and that results in use of force. It's bad for us. It's bad for the subject. It's bad for the community. And I think this is even more appropriate in the climate that we're in today. Typically, we respond as patrol officers in one of two ways when we see these things. So in an old model, and if maybe we can switch to that next slide, we'll go one more. I think we're all aware we've kind of driven in the point that the arrest cycle doesn't work. So we'll kind of show you what the old model versus a more progressive radar model looks like. That'll be on the next slide there. So typically we get a frequent caller, we respond, they're suicidal, they're in crisis, they're having an overdose. Our answer is we respond, we take care of that situation, whatever it is, and we generally send them to an emergency room or a jail. In a radar model, we're going to respond with some information on that subject. I can think of a case that the captain and I have worked on in particular. This subject never likes more than 2 people in her apartment. This subject will never touch metal. So when we go to put her on a gurney to transport her to the hospital, we have to be sensitive to the fact that she has just a weird quirk about touching metal. Apparently it ties back to a situation when she was an adolescent. So it's those small pearls of wisdom. I've been trained in some of our hostage negotiation. We call them hooks and triggers. What things gain us goodwill and what things cost us goodwill. And so when we can respond with those response plans, it makes us more effective, it keeps us safer, and it keeps them safer, and the communities that hire us to do their policing ultimately get a better product. And that's what we're ultimately trying to do. Go on to the next slide if we could. So we touch people in the radar model normally in one of two ways. It's either through the mental health side, or it's through, like what the chief tied into, it's on the criminal side. It's going to be those misdemeanor crimes that nag the community. It's the person that's stealing your mail. It's the shoplifter at Sears. And what we do is we arrest them for their shoplift. They have a warrant. We send a case off to the prosecutor, and we repeat that cycle 3 months later by the time the case has gone through, and the lead folks can touch on that even better. In a radar type model, we arrest that person, so he's just shoplifted the Air Jordans from the Sears. I have the discretion as an officer to make a choice. I see that the behavior was probably driven by addiction. Instead of booking him into the King County Jail or SCORE or the Snohomish County Jail, I take advantage of the Crisis Diversion Center, or maybe I use King County's mobile crisis team. We find something else. As officers, this puts us in a spot where we can broker social services. We can offer a suite of things. Right now, we generally offer you 2 products, a police car or an aid car, but we can offer you another one, and maybe that's crisis diversion, where you're going to get some food, you're going to get networked with, maybe somebody can get you a housing voucher. We can do some other things. And so for us, it's having some discretion and latitude to look at something other than a jail. And that's really what a radar program does. And for cities, where it ties into is it's reduced booking costs, it's reduced warrant costs, all sorts of benefits. It saves us in patrol because we're not doing transports the week later on the warrant that we just booked. There are some very real savings by just looking at something other than a traditional jail. On to the next one there. So I think one of the big hurdles, and as a guy who's on patrol most of the time, I can tell you one of the biggest hurdles that we have is us as officers. When cities hire police officers, and I'm a training officer and I supervise some of our new officers right when they come out of training, we have as police officers this metric mindset, and that is that if we have an arrest, if we have a crime, we have an arrest. Where there's one, there's the other. It's like a T account, and it has to balance. Somebody shoplifts, they go to jail, or there's a case. We need to think differently. I've appreciated the time that we shared this afternoon by some of the lead folks, that we need to remind ourselves that we just don't fix addiction by me going to the motel and telling the guy in room 106 to stop using dope. That doesn't work. I'd like to think it worked. For the first 5 years of my career, I thought it worked, but it hasn't. We need to be more progressive, and as officers, we need to change that culture. We need to recognize that we don't fix it overnight. I don't fix it by booking him into jail. Just my presence and saying stop using heroin isn't working. and we need to be able to work through that. We also need to, I put down there as one of the bottom slides, is that we get what we measure. Right now, as officers, we reward and we evaluate new officers based on the number of on-view arrests. So we'll have 2 officers, and we'll say the one that made 5 arrests last week is better than the one that made 2 or 3. But maybe the officer that made 2 or 3 arrests also facilitated 5 referrals. They acted as a great liaison to the folks on the mental health side. They utilized the mobile crisis clinic twice and took 2 people down to the sobering center. That's something that we're not good as agencies at measuring and rewarding, because we still have this climate that says, how many arrests did you make? So we need to start measuring differently as officers. We need to start as training officers like myself, making sure that we introduce people coming out of the academy to options other than the jail or the emergency room. And I think we'll get there. I think the tides are certainly turning.
Good evening, and thank you all for being here. Hope you can hear this. Just by way of introduction, this is the Law Enforcement Assisted Diversion team. There's 5 of us here tonight, but it's a much larger group. Just by history, I've been in police work for 33 years. The first 31 years was with the Seattle Police Department. The last 2 years have been with the King County Sheriff's Office as the chief deputy. While I was with Seattle in 2011, I was fortunate to be with a group that was about the most myriad different group that I've ever worked in policing with. It included the ACLU, the Defenders Association, a group from the University of Washington, Evergreen Treatment Service Providers. It included the prosecutor's office, the defender's office. It included probably the most important group of all, not only the community, but users who lived within the community that we were working in. And by users, I'm talking about people who were either consuming but not necessarily addicted to, or people who were addicted to drugs. So this group came together because, as you've heard, one of the common threads here is we see a certain cohort of people over and over and over. And for years and years, for me, 33 years, we were doing the same thing over and over. The prosecutors were, the judges were, and the jailers were. And we were expecting a different outcome with the same person, putting them through the same system. I believe Einstein described that as insanity, and it just won't fix itself. So certainly there's a drive in a lot of communities, certainly in King County, and I'm glad to see in Snohomish County there's a drive to try new approaches to old, vexing human problems and the human condition. Basically, I'll explain the outline of what LEAD is, and then each team member will explain what their role is and some nuances of what they do. LEAD is a point of arrest diversion program where an individual, if they have 3 grams or less of any drug, if they do not have a violent criminal history, if they are not a predator, meaning a person who has others sell drugs for them and that person makes a profit, or the person's a pimp, and if they are amenable at time of arrest to an immediate diversion, then the officer has the ability to call, and you'll meet them in just a minute, a very aggressive case manager who will respond to the police station, not take custody, but meet with this individual user or addict or low-level seller and see where they are, see what their needs might be, see how they got to this point. And that takes anywhere from 15 minutes to 45 minutes. And then if that same person agrees and returns within 30 days to meet with that case manager and come up with a mutually agreeable case management plan, then the prosecutor will not file a charge on that specific arrest. And the reason why we included low-level nonviolent drug sellers is because the vast majority of those are not doing it for profit. They are doing it to make money for the middle person, but also to make enough money to either get enough drugs for their own consumption, or to pay the rent, or to buy food, or to put gas in the car. So they were what we call subsistence level drug users / dealers. This initiative is also open to prostitutes, otherwise known as sex workers. There's another option as far as getting into LEAD, which is what's called the social referral. And that was actually offered and requested by the police officers on the street. They said, why should we be the bad guys? Why should it take us having to arrest a person and go through all this paperwork instead of, we've worked this area for years and years and years. We know who the users are, the people who are about to fall and trip and start to use again. Why can't we just refer them and just get them the help they need now? So that's another way to get them into this initiative. There are 4 core principles with this initiative. One is non-displacement. So there's many other people who have never heard of LEAD and who will never be in LEAD, but who have been waiting patiently in line for housing, for treatment, for job counseling, for mental health services. So we built up through private funding and now public funding, but initially it was millions in private funding, money to build capacity to take in the extra caseload of LEAD so we would not displace those others who had been patiently waiting. Another core tenet is non-ownership. What you'll find, anyone who's ever been involved in government, there's usually a police chief, a sheriff, a mayor, a county executive, a county council person, somebody who says, this is my program and this is how it's going to run. When that person leaves office or goes to another office or retires, that program, that initiative usually perishes because it's personality driven. The good story about LEAD, it's been through many mayors, county executives, at least 3 different police chiefs, but it has sustained itself because it's community owned and it's community driven and sustained by the will of all those key participants. The last key core component is that this is harm reduction. Tim mentioned about abstinence. Most law enforcement programs, most addiction programs are based on abstinence, meaning if you're going to be in the program, you got to quit using. That's the only illness in the United States where we say you're sick, but as soon as you get rid of the symptoms, we'll treat you, okay? You can't treat this that way anymore. Certainly we can go after the big dealers, but most of the big dealers aren't using, and they're not addicted. It's the low-level, nonviolent person on the street. So this is a harm reduction initiative, meaning that it took this person 25, 35, 40 years to get to the place where they are. A cop just can't come along, or a case manager, or a prosecutor, or a defense attorney can't come along and go, stop using, and then you get to go into drug court. It's not that simple. So we do encourage no use, but you are not out of the initiative if you do consume, knowing that we are trying to get you to a better place. The whole concept of harm reduction is meeting a person where they are at the time we meet them and having them reduce the harm to themselves and to the community in which they are living so that everyone comes out in a better place. There's been 3 separate studies on this initiative over the last 4 years. One has been the recidivism. Those who have participated in LEAD have a recidivism rate of anywhere from 58 to 68% fewer recontacts or re-entries into the criminal justice system than the same type of person who would have gotten into LEAD, but they just were in a different part of town where LEAD was not being run. The second one was cost effectiveness. It's been shown that it does not cost any more money. And the last one is still going on is the social psycho study that examines the individual. What what are the health outcomes, the social outcomes, the psychological outcomes, the health outcomes for these individuals. We usually give this talk in 8 hours. We've only got about 15 minutes. So you're getting a really thin amount of information here. But I'm going to hand it over first to Chad, who's with the Department of Corrections. He works every day with 2 Seattle police officers in the lead catchment area. And he can tell you what he does. Cathy then, who's what we call a guerrilla case manager. She doesn't sit in an office. She goes out there under the freeways, into the shelters, along with Michael, and they look for their clients. They don't wait for their clients to come to them. Next, you'll hear from Natalie, who's a King County prosecutor and manages this herd of cats. And last, you'll hear from Sokha, who is the manager of the whole program. Chad.
Hi, my name's Chad Winfrey. I work for the Washington State Department of Corrections, and I'm actually a fugitive apprehension specialist with them. So my primary function is fugitive apprehension, to make as many arrests as I can. And I'm on a team with 2 guys that are tasked the same way with the Seattle Police Department. And I'll tell you this, to make a point, is in 2015 alone, we made over 500 arrests, got 8 guns off the street, and had nearly 30 new drug cases that we sent into King County. Having said that, we're also very aware of the human condition and some changes that need to be made. And we are also probably the most involved team within the Seattle Police with the LEAD program. We make more referrals than anybody else. We are dealing with everybody on the street more than anybody else. We make 20 to 30 contacts a day. And the reason I say that on both ends is nobody can sit in a room with me and tell me that you can't do both. You can do proactive police work, and you can care about the human condition and try to make some changes. A big part of what we do with LEAD is making those contacts. And the number one thing that I hear, that's a very important thing. We need to be seeing them. We need, how do I say it? I need to be an extension of the case managers, and they need to be an extension of us, so that when we come back to our meetings and share information, it's very accurate information. We are always asking people how they're doing. One primary reason why we function well within the LEAD program is all the contacts we make. I know if guys are wearing burlap sacks for shoes that week. I know if they have new shoes. I know if they're sick. I know if they've had issues with relapses, where they're staying. And all that information can be given back to a LEAD counselor. And vice versa when I talk to a LEAD counselor. So it's all information sharing. I mean, when I'm hearing a lot of commonalities up here about the human condition, about information sharing, about breaking down these walls that have been up forever. I mean, it used to be a competition between, prosecutors, defense attorneys, police officers, case managers. And if you come to one of our meetings, that's where the real magic happens. I mean, we have 30 of us in a room, and our primary goal is community safety through dealing with that one person at one time, having a conversation from 4 different angles about one person. How do we make the community better by making this one person better? And it's something in that room that unselfishly everybody is on board with. And it's a pretty amazing to watch. I'm lucky enough to have been with the program for about 3 years now. I wasn't here at the inception. I heard they had some troubles trying to get all those people to get along. Go figure. But the cohesiveness in that room, and then on the day-to-day basis where I'm texting Michael, I'm texting Cathy, I'm calling Natalie, it's all very seamless. And that's what it takes. It takes getting all these different factions who have been at odds for all these years, to me, is the biggest thing, and getting them together. Because we all have the same goal at the end of the day. And I think that's the biggest part of what I could share, is getting everybody, as a law enforcement officer, you can still do your job, you can still help people, and you can still information share. You can do all that is possible.
So I'm Cathy Speelmon, and I am the program manager for LEAD at REACH, which is a part of Evergreen Treatment Services. And REACH has been around for 20 years, this month actually, providing outreach and case management, intensive case management services to addicted homeless individuals. I'm actually not running around out on the street very much, a little bit, but I'm supervising and herding the case management cats. We have a staff of 10 case managers and Michael, who's in our audience tonight, who is a screening and outreach coordinator and responds when law enforcement calls with a referral, which is very much in real time. We're going and responding to those calls, and Michael's doing a screening, or case manager's doing a screening with them and kind of identifying initial emergent needs that they might have, really that are about safety in that moment. If there's a health issue or they're hungry maybe, there's something that's going on that we're able to kind of identify those things. And then our case management model is one that's very different from a lot of traditional case management programs, in the sense that we are very much out in the street and meeting people where they are. So we're out looking for them. They have, as Jim mentioned, they have 30 days to come back and complete a full assessment. And if they're not showing up at the office, then Michael or case managers are out there looking for them to try and get them engaged so that we can get that intake done and begin to work with them. Case managers go and find them. We definitely walk with them in meeting whatever goals that they're interested in working on. So rather than coming to the office and getting a referral that I hand you because you've decided you want to go to the doctor and sending you on your way, we're going to probably call and make that appointment together, and I'm going to be more than happy to go with you and support you in the course of completing whatever that step is. So it's a very intensive form of case management. A case manager might spend 4 hours or an entire day with someone, depending on what their needs are and what's kind of happening. So I might be taking you to the doctor, and then we're going to your mental health appointment, and then I'm going to get you to DSHS to try and get your food stamps, whatever it might be. We're really meeting people where they're at and trying to support them in that. As Jim mentioned, we are a harm reduction model, and that means that we really are meeting people where they're at and allowing people to, our goal is to engage with people around what they want to work on. And what we've found, and there's much evidence to support this, around that people actually make more change if you're doing something they want to do. And starting in that place and walking down that path with them. You know, an example might be someone comes in who's addicted and they want to work on employment. And I may know that it may be difficult for them to get employed because of their heroin habit. But I'm gonna, rather than saying, no, we're not gonna do what you want, we're gonna go to treatment, which is not likely to be successful if that's the message. I'm going to walk down that road with them, beside them, and at some point, more than likely, they're going to come back and say, you know, this job thing isn't working out so well because I have this drug problem that I need to deal with. And I think everyone in this room can probably identify with the fact that when someone tells you what to do, you get a little, wait a minute, who do you think you are telling me what to do, right? But when you come to it yourself, you're much more likely to actually take the steps to follow through with that. So that's what the case management job looks like. The other thing that people have talked about that I think is key to lead, and I think these other programs, is about building relationship. It's about building relationship with each other as partners and sharing and communicating. It's about building relationship with the clients that we work with, these individuals that we work with who have not always had the most positive relationships with, be it law enforcement or social service providers or any variety of folks. So our building of those relationships and developing that trust and understanding of each other has been paramount in this effort. And I can't imagine, I've worked in the addiction field and social service field for a long time, but I said this earlier today, I never would have imagined that I would have been working this closely with people in law enforcement, prosecutor's office, and have such wonderful relationships with all of these folks, and that we are all really working towards the same goal. And, you know, at the end of the day, that's what it's about, is really helping folks. So, thank you.
Hi, my name is Natalie Walton Anderson, and I work for the King County Prosecutor's Office in the Criminal Division. And my role is, or primarily my role is to be our office's liaison to the LEAD program, to all the partners that you see here. Ultimately, once somebody is referred to LEAD, my role is to really make sure that they, number one, complete their arrest, diversion, screening, or intake appointment, and then also to kind of aid the case managers to help their clients really navigate the criminal justice system. And that really starts with, number one, just kind of running what, if anything, they have for criminal history. The majority of our people that are referred to LEAD, unfortunately, have a lot of cases that predate their LEAD referral, and because this is a harm reduction model, they are likely and sometimes will be arrested and have new cases that are filed as well. So my goal is to help the case managers really kind of break down some of those barriers in terms of the criminal justice system that really limit their ability to access treatment. For example, a lot of the people that participate in this program have a really hard time getting to court, and so they end up with a lot of warrants that ultimately don't allow them to get housing. So those are some things that we really work on in terms of the prosecutor's office and trying to link up not only their clients and the case managers to either attorneys that can help represent them, but also to provide information and procedures regarding warrant quash hearings, how they can set those types of things up as well. This is supposed to be a diversion program, but like I said, the majority of things that are challenges for the people that are in this program is their criminal histories, but also to any pending cases that happen either pre or post their LEAD referral. And one of the things that we try and do in the prosecutor's office when somebody is engaged in LEAD is to really work with the case managers and their attorneys to come up with some sort of resolutions that would help, resolutions short of incarceration or jail, alternatives that would allow them to continue with any housing or treatment progress they may have earned during their LEAD program. Ultimately, we have many collaborative courts within the prosecutor's office, including drug court, mental health court, veterans court, but typically you have to be in the system in order to access those programs. And with the LEAD program and the arrest referrals, we're hoping that somebody does not have to get a new case in order to access those services, and that's something that they can do through the LEAD program. Ultimately, we have a lot of communication. The prosecutor's office is able to make a lot more informed decisions on whether or not to really file one more drug possession case based on information that we get from the case managers and law enforcement. And ultimately, the goal is still the same. If somebody is accessing treatment and getting services, you know, what is the benefit typically of filing one more drug case? And so that's kind of the goal for the prosecutor's office, is to do that, but also to have the communication with law enforcement, with the case managers, and with their public defenders or defense attorneys to try and come up with a resolution that is short of incarceration and really does further their ability to get treatment and housing.
I think we're actually on time, you guys. We did a good job. I'll be brief. My name is Sokha. I work for the Public Defender Association. We're the project manager for the LEAD program. One of the things that I'm tasked with is coordinating the operational work group meeting, and we kind of touched about it a little bit here today, but that's an opportunity for all of our operational partners, including SPD, including the King County Sheriff's Office, our case managers, ACLU even, to come inside our room and talk about our specific clients and alternatives to incarceration, as Natalie spoke about. It's an opportunity for deputies and police officers to check in with case managers face to face and verbally talk about how these individuals are doing. Officer Winfrey may see someone on the street that he referred into the LEAD program. A case manager who's responsible for that client can communicate to Officer Winfrey about the plan. The other thing I want to mention is also the community aspect of LEAD. LEAD was developed in partnership with the community. So at our operation work group meeting, we prioritize time for the community to report back on LEAD, to report back on the state of public safety in their individual neighborhoods. LEAD right now in Seattle, we're in the Belltown neighborhood, we're in the Chinatown International District, we're in Pioneer Square, we're on the waterfront. So part of my job is to communicate with these neighborhood associations and public safety leaders and really ask them, what is the pulse to your neighborhood, and report back to these operational partners about what we can do. At the end of the day, I think a huge part of what LEAD is a public safety and public order strategy. Individuals that are in the LEAD program, if they're arrest diversion referrals, if they're social contact referrals, they're in the LEAD program, and their criminal behavior is reduced. And I think that's it, and we'll leave it for Q&A now.
We have a few minutes for Q&A, and I actually have a question for Lauren and Caitlin. We've heard all of the officers, I think, and everyone who works in the criminal justice system talk about how the system needs to get more progressive, or that they have made a change in how they think about these problems through these collaborative relationships. But I'd be curious to hear from the social service, social worker perspective, what working with law enforcement, what kind of changes have occurred in working with law enforcement coming from the social service background?
Yeah. Let's scoot this forward. Hi, my name is. Switch. All right. So my name is Lauren Rainbow. I'm one of 2 social workers with the Sheriff's Office right now. And the question you were asking is, what changes have we seen as social service providers on the law enforcement side since this, is that correct?
What changes, it may be an attitude or approach as a social service provider from the relationship with law enforcement?
Sure.
So we've heard a lot of the law enforcement say, we're doing things that we've never done before and never thought we'd be doing these things. Are there equivalents from the social service world that have come from these partnerships?
Well, I think we're all doing a lot of things that none of us have done before. I can speak from my perspective. I have never worked directly alongside with law enforcement as I am in this position, but my prior involvement with law enforcement was more of a brief collaborative. We all had our goals. We all had certain things that we needed to accomplish for our clients in those moments, and then it was just a split. However, in this role, Jesse and I are out in the field all day doing that intensive case management from, sometimes the backseat of a police car, which is interesting for passerbyers on the street next to me. But the main thing that really sticks out to me is the team that we are working with do not have the professional experience or the education or many times the same worldview that Jesse and I bring to this, which has enabled us to do the social work and take the perspectives that we do with our clients. But we are seeing shifts in communication styles with officers and deputies out in the field, working with, let's all just be honest, they can be very challenging clients to work with. You will hit every road bump that you can imagine and 20 more that you really could never have made up if you tried, right? And what I'm noticing is a much higher level of patience, understanding, and appropriate what's the word I'm looking for? Expectations, right? So my definition of what working hard, or, I always tell my clients, I'm not going to work harder at this than you are willing to. That might look a lot different. While I'm spending hours and hours on the phone and faxing and organizing and coordinating these things, for them to show up and meet me at that gas station that's near their encampment to check in, get a McDonald's card, that is their level of working as hard as I am. And we have to learn to appreciate that and recognize that and move forward. And we're starting to see that really in pretty astonishing ways with our deputies. I'll tell this quick thing real quick, but the other day we were out and one of our deputies, he doesn't know it, but he did start to do some motivational interviewing with a client. And Jesse and I kind of nudged him. I said, do you? And he goes, yep. And so it's starting and it's occurring, and it really benefits everybody on the team and especially the client. So, thank you.
And I have a question for you also, Caitlin. Could you walk us through a story or an example of the challenges in navigating the system for the audience who's here, for us to understand why is it that folks who are living on the street might need assistance from a social worker in order to get into treatment or housing?
Definitely. So my name's Caitlin, everyone. I'm the embedded social worker with Everett Police. To answer your question, Hill, the system as it is incredibly difficult for us to navigate, and we do it all day, every day. So for someone who maybe dropped out of high school or has an underlying mental health issue, is addicted to a chemical, a drug, it's a struggle for them to just take care of themselves sometimes. So to navigate the system is almost unfair to expect that they can do that. So it's imperative that we get out there and kind of help them where they're at. Sometimes it's consistent interaction on a daily basis just to establish a trust or a little bit of a relationship before we can even start doing those things. So it's definitely important to have these relationships with law enforcement so we can go out there and have those communications around what services will be best for them and how to go about getting those services and be there to kind of hold their hand through that process.
We have questions from the audience. Could everybody hear that question? So the question is when you encounter individuals who may be out on the streets or in an encampment who do not want services, what is the percentage of those versus those who are out in the street and encampments who do want to have access to services?
So I can respond partially to that. I can't give you an exact percentage. Anecdotally, I can tell you every one of our officers, especially on our outreach and enforcement team, whenever they come in contact with these individuals, they're offering services. Sometimes accessing those services, again, can be a challenge, but we're trying to find out who's interested, because even if we can't get them in right at that moment, if we know they're interested, then we can use our social workers to actually help us get them in. But I was actually shocked at some of the results that I've seen in terms of the number of people that are not interested in services today. And I think that's the key, is today, because as Caitlin mentioned, and I've had conversations with Lauren about this, it takes time with a lot of these individuals, and it doesn't do anybody any good to force them into treatment when they're not ready. You got to sometimes wait until they're ready, and sometimes it takes going back to them over and over and over again until they're finally at that point where they say, okay, I'm ready for services, and then we've got to take them right then. But I will tell you from what I've heard, and I'll certainly defer to both Lauren and Caitlin, because they probably have even better understanding because they're on the streets making these contacts, but that I was surprised at the number of individuals that we were coming in contact with that were not interested at that moment in any services.
And I think that the key is today. So it might not be today when I've woken you up and you just used heroin an hour ago. It might not be today that you want to go to treatment. It might be tomorrow or the next day. But that's why we have the position that we have to go out over and over and over again until we can make the contact where they do feel comfortable going.
Cathy?
Yeah, I was just going to add that I think it's really complicated, right? And one of the things we saw with LEAD in the beginning, and we still see it occasionally, is that even some folks who've opted into the program, they maybe took that first referral, but then they never really engaged with us. Many of them didn't trust. Like social workers working with law enforcement, we're going to have to do something for you. You're going to make us snitch on you. You're going to, that is really hard for people to trust that this was really what it was and is. So I think you're oftentimes dealing with people that don't have very trusting relationships with folks. I would say, over the past, 40 years working with addicted individuals and homeless people and mentally ill folks, that I think everyone wants to improve the quality of their life. I think that how we do that and the path to that is different for everyone. So.
Thank you. Another question? Yes, sir. I'll repeat the question for our,
okay,
because we'll post this video online. And the question is, is there diversity within your teams and your outreach teams, so that as you encounter individuals from different ethnic or racial backgrounds, you can approach them with an individualized fashion?
Absolutely, and that's been a really important, concern for us. And so we have a very diverse staff that does often mirror, and mostly mirror, the clients that we're serving. It's also, one of the other things that's been really great for us is that we also have a lot of staff who come from many of the places that our clients have come from, that they're not peers in the sense that they are all professionally trained and have work experience doing case management, chemical dependency work, but a large majority of them have been incarcerated or been in the criminal justice system. They have been homeless, experienced homelessness, or have experienced their own addiction or chemical dependency issues. And I think that's made a big difference for us, and I think is always important, is that we need to look like who we serve.
I'm sorry, Cathy, can I explain? Respond for a second. I'm a prosecutor with King County. I'm African American, and one of the things that I track with this program, and one of the reasons why I work in this program, is I think it's important to be working in a program and as a prosecutor with collaborative efforts and efforts that reduce incarceration of African Americans. One of the things that we track and I ask on a daily basis is what sort of services are we giving out, and what is the population in breakdown? And I think to date, 58% of our lead participants are African American, and I just want to point that out, number one. Number two, I just want to again just say there is a diverse amount of case managers who are African American, and even law enforcement who are making those referrals. The team that Chad is on, and also some of our bike units that do referrals, there is a contingent of African American officers that do make referrals as well. So even if it doesn't look like it, there are people that are representative here, including myself. Thank you.
I want to add to that too. So as the person of color who does the project management for the LEAP program, I think we have to be really intentional and strategic about how we outreach to different communities, whether they be communities of color, immigrant refugee communities. One of the things that we launched today, and thanks to Natalie, was actually making sure that there's lists of interpretive services available for our case managers when they're doing outreach to communities that are predominantly East African or predominantly Chinese, Vietnamese, what have you. So they have the tools available. So I think systemically within kind of the project management side, we're not perfect, but we have to develop, and we are developing tools systemically inside our program to make sure we are addressing disparity, racial disparity.
And this program grew out of, one of the things, and I don't think Chief Pugel did the introduction in this panel, but this program grew out of a lot of litigation around disproportionate arrest rates of African Americans between Seattle Police Department and King County Sheriff's Office. So this was one of the not necessarily solutions, but answers to how are we going to address that in Seattle as a community.
Thank you for that question. Another question? And the question is, what is available for individuals who are not in the criminal justice system, may have resources and family supports in the community, don't have the other traumas that a lot of the individuals in these programs have. And I'll first say that this epidemic does not draw boundaries around race or economic status. It is affecting the entire community, and that there is no one single solution that is going to work for a broad base of people, and that a lot of these solutions focused on particularly targeted populations. But as a community, we are going to need many broad answers to address this in all the different places in which it touches individuals here. So I don't know if there are other thoughts on that from the panelists.
I'll just touch briefly. Earlier, Chief talked about the PARI program, and I'd like to expand a little bit on that. It is a program based on self-referral. So I actually am working with an individual right now. His mother came across a sergeant who explained the PARI program to her. She went home to him and said, you know, here's your chance. They'll take you. And he walked on down to the precinct and actually asked to speak with Captain DeRoos to get a little bit more information about what PARI is. And so within 24 hours, I was in contact with him, doing an assessment, getting him into a medical detox facility, and he will fly out tomorrow to go to a 90-day residential treatment facility. He's 23, he has a home. He just quit his job because he loved heroin a little bit too much, and he's tired of that life. He's tired of hiding, who he was from his family and from his friends. He was ready to make a change, and so that's something that we're offering to work with. PARI is incredible, to take scholarships, to take insurance, any of that, and we work immediately to get the person in, because that is an opportunity that we need to jump on. When someone is ready, no matter their situation, we want to jump on that.
I just wanted to add one thing to that, and that is, I'm excited that we're able to provide at least this resource that we traditionally have not been able to provide up until this last year. I think it's a gift for a lot of these individuals, and again, it's a process, and it may not be the answer. It is an option. It is a resource that previously didn't exist to us. But you do highlight a very important point, and that is the resources, or lack thereof, that exist. And this is something that we really haven't touched on here today. It may be a topic for another evening, but I think that the social services and the services side are trying to catch up to this epidemic, in that in Washington, we don't have, I'll speak to Snohomish County, we don't have detox facilities readily available for first responders to put some of these individuals into. We don't have some of these long-term treatment providers in Snohomish County. We're having to fly them away out of state to get access to these services. We need to start looking at providing these services here, because the epidemic is here and we need to deal with it here. But you do raise a very, very good point, and I'm very, very sorry to hear of your loss.
I wanted to speak a little bit about, and let me start off by saying, my sincere condolences for your loss, and thank you for having the bravery to share that with us and with this room full of people. Chief Templeman is correct in that we are lacking in resources, not only in the county, but in the state. One thing that our team has worked very diligently on is identifying the programs that we do have access to within the state that are providing a high level of treatment, and sometimes specified for certain populations. So, we have one facility that we really favor for our female clients with co-occurring disorders. We have found that people come out of that facility very empowered and really charged in their recovery, but the support doesn't end there, right? We pick people up, we take them to get their housing voucher, we take them to Fred Meyer to get them everything that they need to move into a new sober living environment, and it doesn't stop there either. We set up their IOP appointment. We drive them to their IOP appointment. We get frantic phone calls saying, I missed my bus, I don't know what to do. We dispatch a deputy and we drive them there. We have only been doing this program for a year now. but we are still in contact with some of our first clients. And though the level of need is slowly decreasing, it's still there. And I think really the basis of what is helping people continue in their recovery is that ongoing support, that ongoing relationship, inviting a bunch of sheriffs and social workers to come watch you get a chip, right? It's that kind of support. Is that available to everyone in this community who needs it? Unfortunately not, right? Because we are a team of 5. You guys are bringing on your other social workers soon, and it's intensive, but I am confident that as we continue to have, successes and building relationships, not only with our clients, but within the community as a whole, hopefully we can continue to expand these programs and reach the people who really need the help the most, when sometimes it's just that perfect timing, and sometimes it's not. But I hope we can continue to expand.
I think we have time for one more question. So the question is, how are social workers and law enforcement officers who are responding to these situations of high crisis and conflict taking care of themselves and then learning from those experiences? And I think this might be a great question for the team from Shoreline and their radar program.
So I'll answer that. I'll keep my remarks pretty brief here. I'll share a personal story, and then I'll tell you one of the things that we've created inside the sheriff's office. So there was a subject named Benjamin who we had arrested a million times. He would shoplift cough syrup and go behind the Safeway. He'd mix it with antidepressants, and just a ton of problems. And he overdosed one day, spent 5 days on life support at Children's, and then passed away. And for us, where we're saddened is every police officer, no matter who we are, always believes that there is that one day where we're going to get redemption. Benjamin, one day, he's going to get it together. This will be the day he doesn't shoplift cough syrup. He's going to figure it out. He's going to get involved in sports. There's that potential that we think is there in everybody. I always tell the story that I managed to make it all the way through my field training program and never drove to the youth service center. It's our fancy word for the jail for youth. And I had to book Benjamin one night, and I go to Google the instructions. He says, don't worry about it, I'll get you there myself. And to have a suspect tell you how to get to jail, that was always my memory of Benjamin. But there was a connection there. So for that moment, he was telling me what to do. He was helping me do my job better. And we feel a connection. I think there's been a subtle takeaway here that these people aren't always likable. They're tough, they steal your mail, they pawn your jewelry. They're not always likable and easy to serve, but we all think maybe today's the day. Maybe today's the day they get squared away. So it does affect us, because I still tell the story now 5 years later of, whatever happened to Benjamin. In the King County Sheriff's Office, and this is independent of radar, we have what's called the PAT team. It's the peer assistance team. And we will, whenever there's a traumatic event, it can be everything from, like we just had a homicide of a child. It can be officer-involved shooting, traumatic events. We just had an officer that sustained a traumatic brain injury in a collision. That was a few months ago. And so we respond. We might do it. So I'm one of our PAT members. We may respond with a micro debrief. So if we have a case, so ma'am, I can empathize with your story, because on my Friday, that was the last case that I took, was a family that went downstairs. They have a split-level home, went downstairs and found very similar circumstance. Their son had overdosed. And so we'll do a debrief. What was that like? How did we work with the family? So we found that those on-site debriefs are very, very good. If it's a major incident, then it would be one of the two folks here on either side of me. It'll be a member of our command staff will sometimes call them, and then it's required. You'll be commanded to appear at this date and time, and we have a mental health professional from outside the department that facilitates that debrief. We call them critical incident debriefs, CIDs. And so we try and do it. We are saddened, no matter how many of us are just blocking and tackling, nuts and bolts, book them into jail, we are sad whenever we lose that future potential.
It seems that at the center of all this and any chance of making progress is that human connection, whether that's through adversaries, within the court system who then partner for a new program like LEAD, or whether it's between an offender or just a citizen and the law enforcement or social workers. It's that human connection that really is the key to moving forward. So I really appreciate all of the panelists' comments and the questions. If you still have questions, I'm sure there are many more. There's an opportunity for you to ask those on the city's webpage. If you go there and look under Safe Streets, there's a way to contact us, and then we will try and answer any of those questions or get in touch with someone who might have an answer about that. We'll also post the video of tonight's presentation. One more note I wanted to make is that on the agenda there was a item that said Safe Streets video presentation. We're going to have a world premiere of our Safe Streets video this evening. Unfortunately, we had technical difficulties and we're not able to do that, but I think it worked out well because we got to use that time to hear from the panelists. But that will be played for the first time tomorrow night at the Everett City Council, and then it will be posted on our website shortly. So keep an eye out for that. And I'd like to ask the mayor to come up one last time with a few closing remarks.
Well, I don't know about you, but I'm very moved by what I've heard, and I'm very sorry for your loss. I lost a dear friend who was like a son to me at 33 from a heroin overdose. So I know where your heart is. I think the difference, because these people have been toiling in these fields for years, and what I call doing the Lord's work, trying to help people. But I think the political will of electeds today, I believe I'm one of those leaders. I think Dave Summers is one of those leaders. I think we have the ability to create the conversation, to pursue the resources, to get the help that's necessary to be able to help people in need and people in crisis and people on our streets. And the one thing that I am absolutely convinced of as I listen to this is providing supportive housing. And we didn't talk an awful lot about it tonight, but providing supporting housing where people can be safe and have the opportunity for treatment of substance abuse or mental illness is a significant step forward to helping people and having that help be successful. You know, we're working on a project to provide 70 units of housing in Everett. If we're successful with that, it'll be 2 years before we're able to do that. We have to accelerate the pace of getting people off the street and getting them the help that they need. So Dave Summers and I are committed to doing that with our councils and looking for every bit of help that we possibly can. The other thing that strikes me about this is all that's going on across this country. We need to re-engage our middle class. We need to open our hearts and our arms to the minority communities. We need to get people employed and break these barriers down if we're going to have an effect, I think, on our collective quality of life and hopefully end the madness that's going on in the world. So I appreciate you all being here very much. I want you to know that I'm absolutely committed to doing everything within my power to make this a better community and a safer community and to help those in need. I do now have homeless people showing up to neighborhood meetings asking for help. I had a community member that was very much like you who came to me whose son is addicted to heroin. We set up a treatment program. Unfortunately, you could almost tell when he said, well, I'll show up Monday, and this was Thursday, that he wasn't ready, and he didn't show up. But that doesn't mean that we stop trying. So this is sort of saving one soul at a time. That's how I view it. So again, thank you very much for being here. Thanks to the panel. Let's give them a hand.